So we have Jennifer McFarquhar and Heather DeBendris here with us. They are uh, part of the Healthcare Associated Infections staff at the Division of Public Health, the Communicable Diseases branch for North Carolina. And we're really pleased that you guys can join us via Zoom. And please feel free to introduce a little more, but I'm going to turn it over to you all.
Hi, Amy and everyone. Thank you so much for joining us via Zoom today. I know the format is a little bit different than we were anticipating, so we certainly appreciate everyone's flexibility. So this is Jennifer McFarquhar. I am a nurse by undergraduate training and have quite a bit of additional education and experience in applied epidemiology. And I now work for the Centers for Disease Control and Prevention. I'm assigned to the North Carolina Division of Public Health, and I work with the SHARP program, which is the Surveillance for Healthcare Associated and Resistant Pathogens Patient Safety Program. And Heather?
Hi, everyone. This is Heather DeBendris, and I'm one of the epidemiologists with the SHARP program. So a lot of my work focuses on the surveillance and response to healthcare-associated infections in general, but antimicrobial resistant organisms specifically. So today we're going to talk with you about some emerging infections and outbreaks, and also review the steps of an outbreak investigation across the healthcare continuum. And we also have an exercise planned, and we'll see how best we can do that with this revised format. Okay. So we're trying to I'm not sure.
Advance the slides.
On your view, are these slides advancing? Amy, can you tell us if they can see these?
No, they can. Okay, great.
Okay, great.
So the objectives of this presentation are on. Oh, okay. So Katrina, let's see. It says the slides are not advancing, and hopefully they are now.
You all,
okay, perfect. Thank you.
It looks like I'm doing it. So.
All right. Okay, you're having to do it. Okay. All right. So, so the objectives are to describe our program here in North Carolina, review some historical outbreak data, and discuss the trends of outbreaks over time, discuss and describe some emerging infections and common healthcare-associated pathogens, discuss the public health significance of these organisms across the continuum of care, describe the 10 steps of an outbreak investigation, and also describe the role that we play in public health and investigating cases and outbreaks in healthcare facilities. So the mission of our program is to work in partnership to prevent, detect, and respond to events and outbreaks of healthcare-associated and antimicrobial resistant infections here in North Carolina. And this is a picture of some of the folks here on my team. So that's myself on the left side of the screen. Dr. James Lewis is our medical director. He's been with us for about a year now. And Heather DeBendris is also here with me in the room. And then we also have two other epidemiologists. Katie Snyder, actually, she just got married, so we need to change that slide to Katie Palladino. And also Savannah Carrico. And hopefully we'll be hiring a health educator soon, as well as an epidemiology program manager. So we're a small but growing team.
Do you all have the slides on, slide presentation mode? I mean, like big, can you do full screen?
So it doesn't seem to be letting us control that.
Okay.
I've clicked it a few times.
Okay. Okay. Yeah, that's strange, isn't it?
Are we just restricted?
Oops.
Oops. But we definitely want people to be able to see what we're talking through. So I'm happy we can pause for a moment and see if we can restart and figure it out.
Yeah. You guys go ahead.
Well, is that working now?
I don't see the screen anymore, Amy.
Okay.
I think we've been kicked out.
Okay. All right. Hold on. Okay. Can you guys see it?
Yay, that's better.
We can see that
Okay.
now. Hopefully the audience can as well.
Okay.
Great.
Yes.
All right. Well, thanks, everyone. Okay, so perfect. Thank you. So within the SHARPS program, we actually have several kind of overarching projects that we're responsible for. And so aspects of our program include surveillance, investigation, and response. And you can actually see listed under kind of this overarching topic some of the activities that we conduct as part of that. But those under surveillance, investigation, and response would be reporting of infections through the National Healthcare Safety Network. We also conduct CRE surveillance, and we also work very closely with our sister regulatory agency, the Division of Health Services Regulation, on infection prevention and breach reporting, and we also monitor outbreaks and assist with outbreak investigation and exposure management. So the second kind of larger tier is prevention, education, and training, and we participate in 2 campaigns. We have the One and Only Safe Injection Practices campaign, as well as our Get Smart or Be Antibiotics Aware campaign, which targets providers as well as the general public in providing education around antimicrobial stewardship. We also participate in drug diversion activities and working very closely with healthcare facilities and local health departments when a healthcare worker is suspected of diverting injectable medications. And then also listed there are antimicrobial resistance and stewardship activities. And most recently, we partnered with the SPICE program on infection control assessment and response visits to all different types of healthcare facilities, including acute care hospitals, long-term care settings, dialysis facilities, outpatient settings, and local health departments. And we also have partners, again, across the healthcare continuum. Another aspect of the work that we perform is monitoring and evaluation, and we do this by conducting data validation of those data that are reported to us. We also use TAP reports, the Targeted Assessment for Prevention reports, just to make sure that people are aware of some of the resources available to them if they do in fact have elevated rates of healthcare-associated infections. And we also look for anything that might be unusual in some of the data that are reported to us. And that, again, kind of goes hand in hand with data validation as well. And then communication. We conduct quite a bit of communication monthly through our data reports. We also create and disseminate newsletters. We try to have quarterly newsletters, but actually I think we've disseminated 2 this year, but they've been specific to Legionella. And then most recently, last week, we actually just disseminated our carbapenem-resistant Enterobacteriaceae newsletter. We provide monthly updates on webinar series that we hold here at the State Health Department. And then we also held a drug diversion tabletop. Last year, we piloted that tabletop, and we've held that a couple of times this year as well.
Heather, I just want to mention, if you can hover your mouse at the top of your screen, mine says Heather Dubendris is control. Oh, good, you are controlling it. Okay. Now can you change to another slide?
Should we try to click?
Yeah.
Okay. Well, I just tried clicking and it's not. Oh, there we go.
I think it's just slightly delayed.
Okay. All right. Okay, so that's kind of a quick snapshot of the SHARPS program here at the North Carolina Division of Public Health. And so I'm going to quickly move to the outbreak summary. And there was actually no way to kind of track the outbreaks here in North Carolina when I came on board in 2011. And so that was one of my first activities when coming on board here, just to develop some sort of systematic recording of outbreaks and outbreak data. I'm getting a little bit of feedback, Amy. So here on the slide, you actually will see summary data from 2014 through 2017. And for that time period, we actually had 901 outbreaks that were reported to us for an average of 225 per year. And this is actually a summary of what those data look like for those outbreaks. And as you can see, a tremendous portion include gastrointestinal and respiratory outbreaks overall, with norovirus being one of the top offenders for gastrointestinal outbreaks. And then in the respiratory category, influenza, and then we've also had some pertussis outbreaks as well, and a smattering of other diseases. So this looks at it a little bit differently, breaks down the outbreaks by setting, and then setting per year. And so as you can see, 72% of our outbreaks for that time frame were reported from long-term care facilities. And we actually expect that to continue. And then obviously you can see that we had some, obviously, from school and daycare, community, healthcare settings, and also restaurant settings. So in 2017 alone, we actually had 320 outbreaks reported to us, with over 6,000 outbreak-associated cases identified. And you can see through the kind of the winter months that those outbreaks did increase in number, and obviously in the number of cases associated with those outbreaks as well. And this is to be expected, just because people tend to be in closer quarters during those winter months and inside, and not spending as much time outside. And this, I like this slide because it actually shows where those outbreaks are located across the state, with one dot actually representing one outbreak. So we'll talk a little bit today about what a healthcare facility is. And I think those of you who are attending this course have a very good idea of what a healthcare facility, what the definition is. But that just includes a lot of different types of settings, including long-term care, skilled nursing facilities, acute care hospitals, critical access hospitals, a specialty care hospital, dental offices, dialysis, and also outpatient facilities. And so why are the investigations in healthcare facilities a little bit different? And I think I'm thinking more here in terms of kind of the long-term care setting, but also acute care hospitals. It's a very vulnerable population. Obviously, these persons are hospitalized or a resident of a long-term care facility for a variety of reasons. They have needs, healthcare needs, that cannot be met outside of, or inside the home. I mean, they have to be met by healthcare providers who have kind of a special specialty in practice, or expertise, I suppose you would say. So it's a very vulnerable population. They're also at risk of infection, and also risk of a higher mortality. And so frequently these healthcare facilities, and in particular long-term care facility, it's a communal living setting. So these people are in close quarters and they don't get out as much. And so they have the opportunity to pass illnesses from person to person, either direct with contact with one another, or also via hands and or the care of healthcare staff. And I think one of the things that's important to emphasize here is that we investigate cases or outbreaks of conditions to prevent or stop the outbreak from occurring, or just to stop the outbreak.
So to illustrate this point a little further, next I'm going to go through bit of an outbreak response. You can kind of see how all these pieces fit together. And we'll talk about some common healthcare-associated infection or antimicrobial-resistant organism investigations that we've been involved with in the past few years. And then we'll round out the day by talking in detail about the steps of an outbreak response. So to illustrate this point first, I'm going to talk about multi-drug resistant organisms, some of which are sometimes coined nightmare bacteria. And so when we talk about MDROs, or multi-drug resistant organisms, it's important to make sure that we're all speaking the same language. So to start with a little overview, this is a comic here that I feel like kind of really encompasses the problem with these sorts of organisms. So the text here, just in case you can't read it, it says, you're the next class of drug-resistant bacteria. As humans continue to abuse and overuse antibiotics, your ranks will swell. So go out there and mutate. And remember, that which does not kill us will only make us stronger. And so when we talk about MDROs, what we're really talking about is any organism that is resistant to a class of drugs that are normally used to treat it. Specifically for this example, we're going to talk about two of these MDROs, the first being extended spectrum beta-lactamase producers, or ESBL. So ESBL, so this is an enzyme that's produced by gram-negative bacteria, and it makes those bacteria resistant to some of our stronger classes of antibiotics, namely the third-generation cephalosporins and monobactam. Now, ESBL infections are considered fairly endemic in the United States, which means that they can be associated with either healthcare exposure or can be community acquired. And they're often spread through direct or indirect contact with colonized or infected patients and contaminated environmental surfaces. And in a healthcare setting, often this is done through, facilitated through healthcare worker hands. So ESBL organisms can be facilitated by the transfer of patients between facilities, which can help propagate their spread. Also, these are types of infections that often affect vulnerable patient populations. And because of their resistance to those strong classes of antibiotics, they can at times be difficult to treat. And some ESBLs may also go on to produce another enzyme, have another mechanism of resistance, an enzyme known as a carbapenemase. Now, when gram-negative bacteria, particularly Enterobacteriaceae, are resistant to our last line of antibiotics, the carbapenems, those are known as carbapenem-resistant Enterobacteriaceae, or CRE. So CRE were first recognized in the United States in 2001. And when we talk about Enterobacteriaceae, we're talking about this really big family of gram-negative bacteria. But most commonly, we're talking about gut bacteria. And these are common examples here, so Klebsiella, E. coli, or Enterobacter. Now, CRE are resistant to carbapenems, which are some of our last line antibiotics, and often they're resistant to nearly all antibiotics that can be used to treat them. There's lots of ways that bacteria can develop resistance, but when we talk about CRE, the type of resistance that we're particularly concerned about is the production of that carbapenemase enzyme, or these carbapenemase producing CRE, or CpCRE. And these are the 5 primary enzymes that we talk about when we talk about carbapenemase production. You don't need to remember these, but just so they look familiar for you in the future outbreaks. So KPC, NDM, VIM, IMP, or OXA48. Now, the reason that we're most concerned about these carbapenemase producing CRE is because they're highly resistant, just like all CRE, but they contain these mobile resistance elements. So those enzymes are located on genes that are on plasmids. So they can easily be shared between bacteria, which helps facilitate their spread. So any CRE is of public health importance, but these carbapenemase producers, because of their ability to share their resistance, are of greatest public health importance, and it's thought to be they're the leading contributors to the spread of CRE. Now, CRE causes a lot of infections, over 9,000 infections in the United States every year. And they can be associated with a high mortality, particularly when we're looking at bloodstream infections. We see mortality upwards of 50%. So now that we're familiar with these two organisms, or types of resistance, I'm going to go into our outbreak example. So in this case, a local health department gave us a call on a Friday afternoon because without fail, that's what happens on Friday afternoons. We figure out that there's an outbreak. And so on April 21st, this call was just kind of a heads up because they had noticed an increase, just generally speaking, in the number of the ESBL producing organisms among patients admitted to their local hospital over the last several months. And this local health department communicable disease nurse was really intuitive, and so she started looking through these cases, and she noticed a pattern, and the pattern was that many of these cases were coming from 3 long-term care facilities. So on that Friday afternoon, we began to talk about what we could do to assess the infection prevention practices of these facilities to make sure that we were preventing any further spread either within or between facilities. So when we got that call on Friday afternoon, there were 4 recent cases that were really concerning to her. And so we talked about those initial control measures. She faxed those results over. And on Monday morning, there were 40 positive labs waiting for us on our desk. So when she started really digging into this, we found that this problem was much larger than we originally thought. So here is an epi curve just to kind of show baseline and then that outbreak time period. So these are hospital ED visits or admissions to that community hospital that the CD nurse noticed an increase in. And you can see if you look at the first few months from January of 2015 going up until October, we're seeing about 2.5 cases per month. And then we start to see this slow increase that really balloons in September of 2016 through the outbreak time period. So through July, where we start seeing a lot more cases. Now the blue boxes here, we're looking at ESBL phenotype, so those organisms that had resistance to 3rd generation cephalosporins or monobactums. And those slashed boxes we'll talk about more later, but those were, upon further lab review, we found that they were also CRE. So they were resistant through the ESBL phenotype, but they also were resistant to the carbapenem antibiotics. And so you can see that this really had been an increase over this time period. So anytime we think that we might be faced with an increase of cases and that we might be in an outbreak scenario, one of the first things we want to do is come up with our outbreak case definition so that we can make sure we're counting things appropriately. So who goes in that outbreak case definition box versus what could just be sort of normal noise, normal cases that we would expect to see at that hospital. So our initial outbreak case definition, we classified as any new CRE or ESBL infection or colonization, because that's the thing with multi-drug resistant organisms. Sometimes you have symptoms and it's part of a clinical infection, and sometimes a patient can test positive but not have any clinical symptoms of infection. So they're colonized, but they can still transmit to others. And we looked at any resident in this county because at the time, anecdotally, we thought they might be coming from specific long-term care facilities, but we want to start with a broad case definition when we initiate our first response. And we looked at that October 1st date as when we thought cases really started to rise. So with that initial information and with our case definition, it did look like there were some long-term care facilities that were implicated. And so we gave some initial outbreak control measures, so just general infection prevention advice for these facilities. So this included gowning and gloving for any patient care for somebody that had an MDRO, whether it was ESBL or CRE or something else, making sure that they were implementing appropriate standard and contact precautions. We reinforced the importance of good hand hygiene and recommended that, if it had been a while since staff had training on hand hygiene, that was revisited. Since, as I said before, often these germs are carried from patient to patient on healthcare worker hands. And then the last initial recommendation that we gave was just to think through the way certain care activities were scheduled to prevent opportunities for transmission. And so what I mean by this is if we had a patient that had a multi-drug resistant organism that needed physical therapy, if that physical therapy could not feasibly be conducted in the patient's room, then maybe we scheduled it for the end of the day so that any equipment that couldn't be dedicated could be wiped down in a thorough cleaning before other residents came into contact with that equipment. The same with cleaning. So if it's possible to cohort staff, so only staff, certain staff are cleaning the rooms with the MDRO patients, or if not, then when it's feasible, kind of scheduling that cleaning for the end of the day. So just trying to think through what opportunities there were for transmission within each of these facilities, and then to try to schedule accordingly. Now, on top of these general infection prevention recommendations, we wanted to really have some boots on the ground to look at what could be happening in the facilities that was propagating transmission so that we could stop transmission and prevent future outbreaks. So we went on site with the local health department and to each of these 3 long-term care facilities. And we had some major areas where we identified gaps and opportunities for improvement in infection prevention. So some of these major findings are listed here. So hand hygiene was fairly inconsistent. So a lot of times folks were really good at remembering to wash their hands upon entering the room, but maybe we didn't observe them washing hands when they left their room. Maybe folks were forgetting to wash hands once they took gloves off. So just some room for improvement certainly in hand hygiene, and that's across the type of person that was providing care. So from environmental cleaning services, nursing staff, CNAs, all in all, we needed to do some education around hand hygiene. Wound care, and I put these specific observations here because I think this is something we see not just in these specific long-term care facilities, but it's a common finding when we go out to do observations, which is interruptions in the flow from clean to dirty, so not maintaining that workspace appropriately, and specifically reusing scissors. So sometimes we go to these facilities and we see that there's a single pair of scissors that's being used to cut clean and dirty bandages, and those scissors are being used on multiple patients. Or we see, gauze and adhesive tape rolls being stuck in pockets of staff and then taken out and brought into other rooms. So all of those things are really interrupting the flow from clean to dirty to ensure that wound care isn't becoming a chance for transmission to occur. When looking at some of those ancillary care service areas like occupational therapy and physical therapy, often these are settings that it's difficult to really think through what contact precautions would look like for an individual, but we did find areas for improvement here, namely not having dedicated patient care equipment. So when you have someone with an MDRO, it really is best practice that gate belts or anything that's porous are dedicated to that patient. And then, like we said, making sure that contact precautions are in place, or that the therapy is occurring at the end of the day, so that those other materials and patient care equipment can be properly cleaned. Contact precautions were implemented to varying degrees, and there wasn't a lot of communication going from facility to facility about these infections. And so what we know is that's a really important part of the prevention process for multi-drug resistant organisms. This isn't something that stays within 4 walls. So as patients are leaving a hospital through EMS and going to a long-term care facility, or vice versa, or being transferred between long-term care facilities, it's really important that that information is known up front so all facilities can have appropriate precautions in place. And this is really how we prevent the regional spread of these organisms. And then lastly, we took a look at all of their infection prevention policies, and there was a need to make sure that those were reviewed and competency checks were in place. So based on those observations, we gave some really specific control measures. In the interest of time, I won't go through all of these, but a huge part of our control measure recommendations involved staff education. So making sure staff were educated in all of those primary areas where we found deficiencies, from hand hygiene to wound care, the importance of appropriate precautions. So thinking about the type of contact they were having with these patients and how to prevent the risk to themselves and to other residents in the facility. We looked at environmental cleaning. We looked at facility communication, as I've discussed. And we can certainly talk about more of these if time allows when we get through the slides, but I think in the interest of time, we'll just keep moving forward. So I want to show you this line listing again, this epi curve again, because we made these site visits before we had any additional information on the CRE cases. But you'll see that red arrow there. So I told you before that the slashed boxes represented cases that also were CRE, so they were carbapenem resistant, in addition to being ESBL producers. And one of those isolates, where that red arrow is, we found out the day after we got back from the site visits, actually, I think, we did some additional mechanism testing. And so in the beginning, when I talked about carbapenemase producing CRE, I mentioned that there were 5 main mechanisms that we looked at. And some of those are more common than others. So this particular isolate tested positive for IMP, which is a mechanism of resistance that we had never before seen here in North Carolina, and is pretty rare nationally. And so seeing an uncommon mechanism of resistance really made us have to kind of, containment became a priority. So if this is a rare mechanism, we want to make sure we're doing everything we can to prevent that spread. It also meant that we had to revisit our outbreak case definition. So as part of the larger community response, we still had that outbreak definition of looking at all ESBLs, but now we also wanted to make sure we caught all IMP producing CRE specifically. So we came up with this second case definition here. And this is really common as outbreaks progress and you learn more information, you make your case definition more narrow based on that insight and information. So through the course of the investigation, you'll see, looking at this epi curve again, we did identify additional cases of IMP producing CRE at that same long-term care facility. And so there was a lot of screening and on-site education that had to occur to make sure transmission halted. And so these three cases you see here at the end of the epi curve were identified as part of that response. So there was lots of ongoing facility education. We piloted an inter-facility transfer form throughout the entire county to make sure that all facilities were aware when somebody had a multi-drug resistant organism. This was really a partnership from all of the healthcare facilities, the local health department, the state health department. We had assistance with testing from CDC, and it really was that combined partnership and commitment to infection prevention that ultimately led to the outbreak halting. And we did not see any additional IMP cases after this time. We stopped seeing new cases within those three long-term care facilities. And then when we saw our overall epi curve from that hospital return to baseline is when we were confident that that outbreak was over. But you'll see here, by the end of it all, we were responding to this outbreak for over 13 months. So it was pretty resource intensive. So that is one example of an outbreak response that we might ask you to work on. I also wanted to take, as we were talking about multi-drug resistant organisms, some time to talk about a drug resistant fungus. So the organism you heard about previously, CRE, as of October 1st is now reportable here in North Carolina, and Candida auris is also now reportable. So Candida auris is a fungus, and it can cause very serious infections. Often when C. auris has been identified, it's caused infections in the bloodstream. And when we see those sorts of infections in the blood or in an invasive infection that affects the heart or the brain, mortality has been close to 1 in 3 patients. So this is a very serious infection. One of the things that makes tracking and responding to C. auris particularly difficult is that it can be hard to identify. So with the current tests that are available, there are lots of other organisms that C. auris can be misidentified as. So based on the type of testing your facility is using to identify yeast, it might come up as a different kind of yeast. So this is something that we're considering a global health threat. So Candida auris had never before been identified prior to 2009. And I have some slides that I'll show in a bit that shows that progression. As I mentioned, often the infections it causes are very invasive with high levels of mortality. It also, like CRE, can persist in the environment for long periods of time, so it makes those infection prevention measures surrounding environmental cleaning particularly and hand hygiene extremely important. And almost all cases of transmission of C. auris are in the healthcare setting. So this is a map here that shows Candida auris was first identified in 2009, and it got its name auris because it was identified in the ear canal. But since then, it has emerged pretty much globally. So you can see these are some of the first sites of infection. And then as of September of 2018, you can see that transmission has happened across the globe as folks travel and seek healthcare in different countries. In the United States, clinical cases of Candida auris are slowly increasing. So you can see that overall, when you look at this map, it looks like many states have not yet identified C. auris. What I think is really important to look at here is the overall number. So in the 11 states that have had cases, there have been over 433 confirmed cases. And often these are part of individual responses going on in healthcare facilities. So you identify one case, and then through screening and infection prevention assessment cases, you identify those subsequent cases. So in North Carolina, we're very lucky that we have not identified any Candida auris to date. However, it is now reportable, and that is because we really see this as a public health priority. So we want to identify that first case so we can stop it from spreading throughout a facility and throughout the state as a region. We've continued to send communication as it's become available. So this really is an emerging infection. So data are changing all the time, but we're doing our best to keep those communications flowing out to our facilities, starting with the first CDC alert that went out in June of 2016. We've had several provider alerts and requests for reporting over that summer. Some updated information became available about the importance of enhanced cleaning of patient rooms because of its ability to persist in the environment. So we shared that in a provider memo in 2017. We were part of a group of co-authors that created a standardized case definition for C. auris reporting nationally. And then, as I mentioned, as of October 1st, we've added this to our reportable conditions list. The only thing that I want to make sure I mention about C. auris is if your facility suspects C. auris, even if you haven't confirmed it, we're available to help facilitate that confirmatory testing, and we're also available to help provide guidance on the infection prevention response aspect of it. So hopefully you've all received our provider memo, but we can definitely share that after the call as well for some of that general information. And general infection prevention measures here are similar to what we would recommend for CRE, but they really talk about strict adherence to contact precautions, having a private room, making sure hand hygiene is being performed every time it's appropriate, so after contact with the patient or their environment. And then the recommendation for the EPA disinfectant that's effective against C. difficile spores is something that came out as these cases started to spread because it is so persistent. And then we also are available to help screen contacts if you have a confirmed or suspect case of C. auris. So the process here for preventing and controlling the spread of Candida auris really is to identify and treat, but then the big focus on strict adherence to infection prevention measures. Overall, just to wrap up MDROs before we turn it over to the next type of infections we see in healthcare settings, we're working to first to detect, so that involves increasing awareness and access to testing. We're able to do that through making our reportable condition changes, through working with CSTE to draft national guidelines. We have an antibiotic resistance laboratory network, also known as ARLN, that helps facilitate that confirmatory testing when needed. And then once we detect these MDROs, the next step is to contain them. So our priority here really is rapid response and containment. So an aggressive response to even a single case. So we're not waiting until it gets to that outbreak point before we're preventing transmission through infection prevention assessments, interfacility communication, and then overall long-term prevention is always the goal. So we do that through stewardship efforts. We're involved in educational campaigns like Jennifer mentioned, as well as antimicrobial resistance subcommittee we work on here, the STAR Partners Initiative, which some of you might have heard about. And then the big push really is on education, which is a collaborative effort with many of our statewide stakeholders and partners. But we have lots of webinars and trainings and actual resource documents available as well. And so that is the overall picture of what the state is doing. And I just want to end on a reminder as to why it is so important for us to be working together. I don't think that CRE or C. auris, any MDRO, can be handled by a single facility. And this modeling, I think, really drives this home. So this is some work that CDC did. So we're assuming that this is 5 years after CRE enters 10 facilities in an area that has regular sharing of patients. In that first gray bar, what you see is the status quo. So some facilities maybe are doing aggressive work to prevent CRE. Some facilities might not know what CRE is, and so those cases go without contact precautions. So some folks fall in the middle. And what this modeling suggests is that 2,000 patients, or 12% of those patients in that area, will have CRE by the end of that 5-year period. Now, the next bar is a little more promising. This is looking at independent efforts. So all of the facilities in the area start independently looking at their stewardship programs. They are looking at their infection prevention, but still nobody's really talking outside of those four walls. And so slightly fewer cases are seen here, 1,500, but that's still 8% of the patient population. But what I think is really inspiring and hopeful here is that last bar, which is a coordinated approach. So everybody's working together. We're involving public health, nursing homes, transport services, hospitals. When everybody works together to really coordinate this approach, we can get that CRE impact down to just 2% or 400 patients in that same 5-year time period. And with that, I'm going to turn it over to Jennifer for Group A strep, and I think we'll try to save questions for the end.
Yeah. So thanks, Heather. So we'll continue on with a discussion about two more bacteria that we receive a lot of questions about, and we conduct quite a few investigations on in the healthcare setting. So the first of those are Group A strep, otherwise known as, or Group A streptococcus. So Group A strep, it's a group of gram-positive bacteria. They're kind of spherical in shape. Commonly found in the nose or in the throat and on the skin. So you might hear of strep throat, and this is the bacteria that causes a strep throat as well. But it can very quickly accelerate to invasive infection in certain types of healthcare settings, and specifically long-term care settings. So long-term care facility mortality risk. So why are we so concerned about this? Well, between 1,100 and 1,600 people die annually in the United States as a result of invasive Group A strep disease. Long-term care facility residents, just again by nature of what we talked about previously, it's a vulnerable population and in very close quarters, but they're very susceptible to illness and disease, and obviously have a higher risk of mortality just because of their underlying condition. But they are at increased risk of death from invasive Group A strep, up to 1.5 times higher than the average population. And the mortality rate for an invasive Group A strep infection is about 10 to 15%. So I'm going to describe here recent outbreaks, actually been over a year now, but two long-term care facilities in a county in North Carolina. These facilities were known as what we call sister facilities. So they were owned by the same parent company. But we were notified of cases of Group A strep in both of these facilities. And so as Heather actually stated about a case definition, we developed our own case definition for this investigation. And that case definition is here on the slide. New Group A strep infection or colonization identified by culture in a resident or symptomatic staff member of either of these facilities, A or B, with a specimen collection date on or after December 1st, 2016. So part of our public health response, when we're notified of cases of illness in long-term care settings, or in any setting for that matter, for Group A strep in particular, we conduct a retrospective chart review, which means we go back in the medical records and we look to see if there are any symptomatic individuals, and then we go ahead and we test those individuals. We'll survey healthcare workers for symptoms of Group A strep, and again, this can present itself as a sore throat, so we would ask about some of those symptoms we might expect healthcare workers to present with. We would culture close contacts of residents in particular, and those are primarily what we would call the roommates of those residents. We would conduct 4 months of active surveillance going forward, and then we would also conduct a site visit to assess infection prevention. So, of course, we did conduct a site visit for this investigation, and we identified several risk factors, infection prevention risk factors, that might have aided the spread of Group A strep among these facilities. So there was, we noticed that increased staff contact was linked to illness. These patients had significant nursing needs. There was a lot of non-intact skin and wound care being performed, and I know Heather actually talked a little bit about wound care already and some of the findings from the previous investigation, and those findings were no different in this situation. So again, there was a lot of wound care going on, and the scissors were being shared between residents, and that is something that's not a best practice. These patients were also highly immobile, and they required, bed baths for many of these patients. And so we identified, again, poor hand hygiene was one of the things that we identified as a risk factor. The wound care was inappropriate, and there were also staff that were working while they were sick. So in addition to that, we gathered the isolates that we could, and so we submitted isolates from 15 cases, so 14 residents and 1 employee. We submitted those isolates to the Centers for Disease Control and Prevention to determine how related these strains were. And they conducted serologic and molecular typing as well as whole genome sequencing. And this is what we found. So of those 15 isolates, 14 were highly related. So 14 of those 15 isolates, so 13 residents and 1 employee were basically the same T-type and all had the M-type 89. And again, the whole genome sequencing, which really tells us how related they are, indicates they were closely related with a maximum difference of 3 single nucleotide polymorphism between the sequences. So, well, we can't really say that it's identical. They were highly closely related. So, and that indicated transmission among the facilities. So this is our EPI curve for that investigation. And again, that was we were notified in January, and when we looked back, we did find additional cases in December that were related to this investigation. And so this investigation spanned about 7 months. But we did identify 24 cases, and we had both staff members as well as residents that were affected. So in summary, 24 cases. You can see here the breakdown between both of those facilities. We had 10 cases, including 8 residents and 2 employees in facility A, and 14 cases, including 12 residents and 2 employees in facility B. And we did actually have a fairly high case fatality rate for this because we had 6 residents die. And it was very hard to say if it was directly related to this, but it certainly, they had some underlying conditions, but they were in fact infected with group A strep. And so that case fatality rate was 25%, which if you remember back to a previous slide, I said that rate was about 10 to 15%. So this was a much higher case fatality rate. So in summary, all of the elements of our investigation, the epidemiology, the laboratory, as well as the site visit assessments, indicated substantial infection prevention gaps, and supported the conclusion that these were related outbreaks. Again, if you recall back the molecular typing that was conducted, the whole genome sequencing that was conducted at CDC. And there was actually a shared employee between these facilities. And so it's difficult to say, we're not actually able to say whether the individual was the source, but we do know that that individual was the link between the facilities. And that individual did have a strain that was highly related to the others, to the residents as well. So that is group A strep. So I'm going to move on and talk about Legionella or Legionellosis. So Legionella is caused by inhalation of a bacteria, Legionella pneumophila. And again, that is inhaled. It's inhalation of aerosolized water droplets. And we can have 2 different manifestations. One is Legionnaire's disease, which is pneumonia. It's a more serious manifestation. And then Pontiac fever, which is a less severe manifestation. But the risk factor for Legionella, and particularly Legionnaire's disease, are greater than 50 years of age, individuals who have currently or previously smoked, and also have compromised immune systems. So the incidence of Legionellosis has been increasing in the United States as well as North Carolina. And so we've been monitoring this very closely in North Carolina since we started noticing the increase, again, around 2013. But in 2014 is when we started paying particularly close attention to it, because we actually had 5 outbreaks of Legionnaire's disease in long-term care settings. So a couple of investigation steps to keep in mind when you have Legionella and you are trying to determine if you do have an outbreak. one of the things that kind of the gold standard for testing of individuals is the laboratory test. It's a urine antigen, or a UAT. And the other thing that we can look for is radiographic evidence of pneumonia. The risk factors that we would look at for Legionella, especially with investigating in a healthcare facility, are travel, water exposures, and then particularly we would be concerned about the healthcare exposures. And so what we would look at with determining whether an individual was in fact infected or whether Legionella was associated with a healthcare facility was looking at the time frame. So we would look at the 2 to 10 days prior to the symptom onset or the UAT that was collected on the individual. So if the individual was in a healthcare setting for the entirety of that 2 to 10 day period before symptom onset, then we would say that person, the Legionella was acquired in that healthcare facility. And then, so we would say that would be a confirmed case of healthcare associated Legionella. And then if it was less than that, we would conduct additional investigation, but we would say that it was possibly healthcare associated. So that's kind of the difference with the healthcare exposure. So it's a very kind of a unique case definition, as they all are. But we would ask a lot of questions again around, are we sure that they did not travel outside of the healthcare facility, or were they in that facility for the entirety of that 2 to 10 day period? And then we would also look at the clinical symptoms. So ask about fever, cough, when did that start? We would look for the radiographic evidence of pneumonia, those chest x-rays, and we would also ask about previous hospitalizations. And I already talked a little bit about the healthcare exposure, that 2 to 10 day period of time being the most important. And here that's elucidated a little bit more when we ask the question, was the patient in a healthcare facility during the 10 days before symptom onset? So you kind of create a little bit of a timeline. When was the patient admitted to the facility? When did the patient start? And where did the patient go during the 10 days before symptom onset? And I have also talked about this a little bit already, with a definite healthcare associated case being that person who was continuously in the healthcare facility for greater than or equal to 10 days before illness onset. And then the possible, meaning there's a little bit of a gray area. So the individual was in a healthcare facility for part, but perhaps not all of the 10 days before illness onset. So other responses of interest that we have participated in here in the SHARPS program of the Division of Public Health are listed on the slide. But again, so it can be a local response, whether it's in a county, it can be across the state. But then we also respond on the national level. So if there's a national call for cases, whether that's usually involves some sort of a product that we would disseminate information on and ask, kind of conduct a call for cases, if you will. So we've looked at non-tuberculosis, mycobacterium, and heater-cooler units. And we've also looked for cases of Burkholderia cepacia, potentially associated with liquid docustate.
And as you'll see here, unlike other subject areas, it's not any particular group of organisms that defines when we get involved, but it really is the setting. So it's anything that's a result of interacting with healthcare kind of falls under our purview.
Exactly.
It's a wide variety.
That's a very good point, Heather. So I think that actually brings us kind of to the conclusion of the discussion today as far as emerging infectious diseases, and kind of begins kind of a natural breakpoint for beginning the discussion around outbreak investigations. So Amy, I don't know, do you want to pause for a moment and ask for questions, or should we continue on?
I think that's great to see if we have some questions. I'm going to just take back the screen for a second and invite people to use the chat to allow us to communicate with you. We have 51 participants, so that's terrific. And be sure and let us hear from you. And you can do that by clicking on chat and then typing your message in kind of at the bottom of that column where it says type message here. Maybe we can go ahead and set up the, well, we're not seeing anything at the moment.
Okay.
Jennifer, of course, we've just invited folks, but we'll monitor that and make sure we get questions answered as they come.
Great. No, that's fine. So we can just proceed with reviewing kind of the 10 steps of the outbreak investigation and maybe pause again and ask for questions before we move on to the exercise.
Great.
Yes, I think this is where you guys will kind of have to bear with us. Usually we like this part of the presentation and the case study that we have to be really interactive, but we'll do as best as we can to keep it interesting and engaging for you.
Okay, so you guys can go ahead.
All right, thanks, Amy.
Do we have control of our slides again, Amy?
Again, my message says waiting for Heather to control your screen. So
okay.
There you are.
Oh, now we go. Okay, it just switched over.
There we go.
Perfect. All right. So there are many reasons to investigate an outbreak. I'll just move to the second slide. So to identify and describe the source, describe new diseases or learn more about known diseases, identify populations at risk, evaluate existing prevention strategies. Of course, we want to know if our control measures are working appropriately. It's an opportunity to educate the public about disease prevention. Also, in line with the public, it addresses public concerns. We can also develop strategies to prevent future outbreaks from occurring. It also fulfills our legal obligation and duty to care for the public. And of course, last but not least, it's an opportunity to end the outbreak.
So when we're looking to start an outbreak investigation, there are some guiding principles regardless of the setting, regardless of the organism. Firstly, we want to be systematic. So we're going to follow the same steps for every type of outbreak. That includes writing down our case definitions so we can remember them, and making sure that when we're doing case interviews, we're asking the same questions of everybody. Along the way, we want to make sure we're stopping frequently to reassess what we know. Based on the information we've gained, do we have to change a case definition? Should we be asking new questions, or should we be including different people in those questions? Are there additional tests that need to be performed? We often use tools such as line lists and epi curves or an epidemic curve to look at these data in different ways to help us find clues to what might be causing the outbreak. And we are all along the way applying control measures. And lastly, regardless of the type of outbreak, it's always a coordinated effort involving multiple partners.
And here on the slide are actually the 10 steps of an outbreak investigation. And so in your line of work, you actually might see a different list, but these are the 10 steps that we've chosen to abide by here in North Carolina. And so I'll let you familiarize yourself with those. I'm not going to necessarily read them out to you, but I want you to also keep in mind that these steps may occur simultaneously or be repeated as new information is learned. So I think, very frequently we'll gain a new piece of information and then kind of go back to the drawing board and say, okay, well, how does this change our investigation or our case definition?
I guess before we get too far ahead of ourselves, we have to stop and make sure we understand what we're talking about. So what is an outbreak? This is, generally speaking, an increase in cases above what you would expect for that population in that area for that time. So this can look different for different types of outbreaks. So in some cases, a single case might be more than you expect if we're looking at measles in a vaccinated population. And in some cases, it might be more cases than that because you have baseline transmission, like during flu season. Our general rule of thumb, though, is an occurrence of 2 or more epi-linked cases. And when we use the term epi-linked, we're looking at person, place, and time. Yeah.
And so one of the things that we want to do, talking about an outbreak, trying to determine, do we really have an outbreak? We want to verify the diagnosis. We want to know what we're dealing with. So we will do this a variety of ways. We'll review medical records if we have them, and also laboratory reports. We'll talk with patients. We'll talk with staff members, family members. We'll request additional testing if needed, additional laboratory testing if needed, and also consult with the local health departments, the hospitals, and the state public health lab, and even CDC in some instances.
We might just be on a delay.
Sorry, we're trying to get to the next slide. It's pausing for a moment.
There we go. So hopefully some of these steps sound familiar based on the responses that we've just presented you with. Hopefully you'll hear some of these common themes. So the next question we have to answer is what is a case definition? So we've showed you a few of these earlier on in our presentation, but essentially this is just our way of identifying cases. So it standardizes the investigation for a specific outbreak response. So you'll notice in those case definitions we presented earlier, they were very specific to the community, to the time period, and to the organism. And so we're still looking at those same 3 components of person, place, and time in any case definition we provide.
Sorry, I guess we're on a delay again with the with the slide set. There we go. There we go. Yeah, so as Heather just stated, so we're looking at those 3 components of person, place, and time. So when we look at the person, we want to describe the type of illness or any characteristics or anything about that might help us in looking for additional cases. The place, we'll look at a location, whether that's a healthcare facility or a county, and then also a time. It's very important to include time when exposure or illness occurred.
There we go. And so essentially this is just telling us who do we put in the box. So who do we need to investigate further? So in this example, this case definition is looking at an onset of nausea, vomiting, or diarrhea in a specific person, so a patron of a specific restaurant, within 7 days of eating or drinking a food or beverage from that restaurant.
And so using that case definition, we've identified, it looks like 16 people who would fit that case definition. So one of the next steps that we would use, and it's actually very helpful to look at our data this way, it's called descriptive epidemiology. So it provides, again, a way to characterize a health problem. It helps you to describe what has happened. It answers the who, what, when, and where questions. And that's the person, place, and time that we've actually just talked about. But it's, again, a graphical representation. And so we frequently look, kind of create a line list and epi curve to help give us a picture of what that looks like.
So we're talking about a line list. We're looking at describing the persons and places. And when we're looking at the epi curve, which you saw a few examples of earlier, that's really getting to that time component. So in the line list, we're recording specific information about each case, and it's a quick and easy way to review and to summarize data as well as to update those data as information comes in. So we'll show you an example here in a second, but generally speaking, we include basic identifying information, we include demographics about the cases, clinical information, symptoms as they're relevant, any exposures or risk factors, and each row is going to be data for a single case. And these can be kept on pen and paper or using Excel or some other electronic format, which is the example we've shown here. And so you can see in this example, we have first name, last name, date of birth, and gender. So some basic demographic information here, some addresses. And if we kept scrolling along, you would start to see some of that clinical information, maybe if they were symptomatic or not, as well as any common exposures they shared.
And so if the slide, let's see, if we can get it to advance, we'll talk about EpiCurve. There we go. So the EpiCurve, the epidemic curve, is a visual representation of cases over time. And we've shown you a few EpiCurves already today, but it can describe many different things, including the magnitude of the outbreak, how many people were affected. The number of cases occurs on the vertical or the y-axis, and the time period is usually placed on the horizontal or the x-axis. And you can also tell a couple of different things by the EpiCurve. You can tell if it's what the type of the outbreak is. So if it's a point source, if everyone was exposed at the same time on the same day, we consider that a point source, and usually has kind of a nice peak at the top of it, a nice bell curve. And then another type of outbreak is a propagated. And so it kind of just moves along, and you might have a couple of peaks, or it might be really hard to tell where that peak is, and that's a person-to-person transmission. Oh, and there we go. I just described those to you. So the point source, again, has that sharp upward slope and a gradual downward slope. It describes kind of as a common source of where were people affected. The period of exposure is usually brief. That's important to take into consideration as well. All right, and this is a very quick and clean example of a point source outbreak EpiCurve. And then the propagated that I did just mention as well, that's what we consider the person-to-person transmission. It could have progressively taller peaks, or it can just kind of move along, just kind of waving up and down. Generally indicates person-to-person transmission, and it can last a very long time and may have multiple waves. And we see this every year with influenza. And this is kind of an example of a propagated or a person-to-person outbreak EpiCurve.
So when looking at those outbreak steps, you also saw one of those steps there talks about generating hypotheses. And so when we talk about that, well, what is a hypothesis? So this is just a statement that's going to help us describe the why and the how. So our descriptive epidemiology gets at the who, what, and where, and then we want to know why and how. So these are our best guesses based on the data that we have. So there's lots of different ways to generate hypotheses. One great way is to look at the existing body of literature, so to do a lit review and see other outbreaks that look similar to the one you're dealing with. What were their possible explanations? We also rely on, okay, did we lose the screen there for a second? There we go. Hopefully everybody can still see the slides. So we also rely on that descriptive data. So by looking at the EpiCurve, for instance, we can start to generate a hypothesis if it looks like it's a point source, that we're looking for a single exposure versus that propagated outbreak. And then sometimes we also rely on open-ended interviews. So we might do some candid questions with select case patients to try to learn more to generate these hypotheses. So then once we have these educated guesses, we have to figure out a way to examine these or evaluate these hypotheses. And so one way is to look at the established facts, and another way is to perform an analytic study. So you might hear something called a case control study or a cohort study, where we're actually assessing the possible exposures or explanations equally, looking at both ill and non-ill persons. And we might do that looking back in a case control study or going forward prospectively and looking at a cohort study.
Yeah, in each investigation, not all investigations actually kind of conclude with an additional analytic study, such as a cohort or case control study, but sometimes it does.
sometimes maybe the laboratory evidence is enough to try to, along with the other facts, to kind of confirm that hypothesis. But it's just important to know these words and to know that sometimes they'll be necessary.
So I think the next slide for us is actually control measures. And so when should control measures be implemented immediately? And this should happen whenever the source is known. So if you know the source of an outbreak, then you want to implement control measures immediately. And so what exactly does that mean? Well, if you suspect that it's actually a food source, then you would take that food out of circulation and, destroy it, save some of it perhaps for the local health department or environmental health to come in and conduct additional testing on that. But you would just want to remove it so that no further illness can occur from that. And then, another instance of when you would implement control measures immediately is if there's a continued risk of exposing others or being exposed. And, and one of these issues might hit a little bit close to home, but that can also be a healthcare worker suspected of diverting injectable medications. And so, again, control measures can be implemented at various times throughout the investigation. Usually, what you'll do is take the information you have immediately, and you'll make some initial control measure recommendations. So they're applied as soon as possible, and they may change during an investigation.
These next few steps talk about what to do once you've kind of gone through your control measures, you've done any epi analysis that you're going to do, and I think this is a step that we don't ever want to forget about, which is to communicate these findings. So we want to be communicating with the team that's dealing with the response, as well as external communication. So if there are other healthcare providers or facilities that need to be looped into the response, sometimes it's necessary to have some risk communication messages go out to the public or the media. And then we also want to, in the end, kind of summarize what we did in a final outbreak report. And this becomes a record as well as a resource for us to look back on when we have similar responses in the future.
Yeah, and last but not least, we also want to maintain surveillance. And why do we do that? Well, we want to make sure that the outbreak is over, that we don't have additional cases that are occurring, and also to assure that a secondary outbreak is not occurring. And of course, to evaluate or document the effectiveness of the control measures as well. Is there something that we need to do differently next time? That's kind of a, every outbreak is a learning opportunity for us as well to determine what went well and what did not go well, and do we need to change something for the next investigation. And then one of the last points that we like to make about surveillance, how long do we continue surveillance? And our general rule of thumb has been to maintain surveillance for 2 average incubation periods for that illness following the last date of illness onset. Again, and that is just to make sure the outbreak is over and to assure that there are no secondary cases occurring. All right, so in conclusion, that was a very quick summary of the 10 steps of an outbreak investigation before we move on to our case study. Epi investigations are an essential component of public health and also of healthcare, and they present opportunities to characterize known diseases or learn about new diseases, identify any other populations at risk that we were not aware of, evaluate program policies or existing prevention strategies or control measures. It's also an opportunity to train not just public health staff, but healthcare staff or other staff. It's an opportunity to educate the public and to help calm their fears. And it is one of our legal obligations here at the Division of Public Health to conduct outbreak investigations. So we provide that duty to the public. And I think last but not least, the 10 steps of an outbreak investigation, again, you might see some steps that are different in other steps of outbreak investigations, but these, no matter which ones you do follow, they provide a systematic framework necessary to investigate any outbreak, just to make sure that you don't miss anything.
And so I'm sure as we were going through these as infection preventionists, you likely realize you're doing a lot of this work on your day-to-day basis anyway. This is just the framework that is provided to make sure we're systematic about it. And so it may not always be necessary to involve the state health department, but we just wanted to talk through when we might be able to assist you in your outbreak. So we can just help you determine, is it an outbreak? So if you're not sure, if something looks off and you want to hear, more of a bird's eye view of what's going on in the state, or you just want to talk to a subject matter expert, call public health. We're happy to talk that through with you. That's a large part of what our EPI call service assists with. We can provide guidance and tools as well as on-site support. We can also help with facilitating and coordinating calls with partners, so we can help engage those other stakeholders that might be external from your institution. And we can assist with providing those written recommendations. So we talked about control measures in the examples we provided, as well as in the steps of the outbreak just now. But all of those control measures are based in science. So they're based on the observations that we've provided. We tailor those written recommendations, but we're always basing those on guidelines from CDC or other guidelines out in the existing literature.
Yeah, and so I know it seems a little bit frightening sometimes to call public health, but what happens when you do call us? I think one thing it's important to make clear is that we don't want to take over the investigation, but we definitely can provide support and resources and guidance. But we can assist you with a data review, whether that's looking at literature or also assisting with sort of the clinical investigation or the review of medical records or laboratory review as well. We can also assist with, providing guidance and on-site assistance for environmental investigation. Just kind of, sometimes it helps actually to have another set of eyes, looking at something, it's a fresh perspective, and we might see things that you didn't see, in your daily work. We can also assist with control measure recommendations and also providing communication and education for residents, our family members, and also the public. And I know we've actually been on site before when facilities were having kind of the resident and family interactions and a time for the family members to come and ask questions. And so we've provided that resource to the facilities. And we can also provide laboratory support. So, our state laboratory is available to conduct testing, but we can also, if we have enough data to support, we can also engage CDC in the process of providing laboratory support.
And we're non-punitive, so we're there for the same reasons you are. We're there to protect your residents and patients and make sure that we're stopping any patient safety issues. So it doesn't have to be a scary thing to call public health.
That's a very good point.
We have lots and lots of resources available. Too many to list on the slide, but here are some of the common resources for some of the things we've talked about today. So some CDC recommendations for MGROs, particularly if you're looking at exposure investigations, so whether that's a bloodborne pathogen exposure due to drug diversion or due to any circumstances, the administrative code that gives us the ability to help you out is listed here. Some injection safety resources, as well as antimicrobial stewardship guidelines. So I know we've got about a half an hour left, and with that time, we're planning to kind of go through a case study exercise that will hopefully bring all of this together. But if there are any burning questions before we get started, we would like to save the time for that as well.
And I think I saw one pop up here. I'm not sure how to retrieve it. Let's see. So this is from Elizabeth. Are there lessons to learn from the adenovirus outbreak in New Jersey? Too soon, too late? I guess my fear is I'm missing the trends. That's actually a really good question. I was just meeting with colleagues last week, and this outbreak was a point of discussion for us. And so I think the lesson here is that the facility was aware that these cases were occurring, and they did not reach out in time to implement some of the control measures that could have been implemented to stop this outbreak from spreading and from becoming worse. So it is, this was a very detrimental outbreak, and So I'm very saddened that it occurred, and so many of the children were affected. So I hope that answered the question. Are there any other questions that we can address at this time before we move on to the case study?
Okay, well, we will continue to monitor that Q&A box, and Amy, if you see something come through, please feel free to interject.
There we go.
Okay, so the case study, like I said, this is normally a little more interactive, but we'll do our best with the constraints of the webinar. So we're going to look at an outbreak of a GI or gastrointestinal illness following a church supper. And this is a really famous example. This is something that CDC uses to help train some of their epidemiological intelligence officers. And so this case study is based on real life examples of an outbreak that happened in the 1940s. So you can see that the principles and the systematic process don't change over time, which is good to know. So I guess I'll just start with the background. So in this example, on April 19th, 1940, a local health officer in the village of Lycoming, Oswego County, New York, reported the occurrence of an outbreak of an acute gastrointestinal illness to the district health officer in Syracuse, Dr. Rubin. Dr. Rubin is an epidemiologist in training, and he was assigned to conduct the investigation. When Dr. Rubin arrived in the field, he learned from the health officer that all persons known to be ill had attended a church supper held on the previous evening of April 18th. Family members who did not attend the church supper were not ill. So accordingly, Dr. Rubin focused his investigation on this supper. He completed interviews with 75 of 80 persons known to have attended, collected information about the occurrence and the time of onset of symptoms, as well as the food consumed. Of the 75 persons interviewed, 46 persons reported gastrointestinal illness. So the first question we have for you is, would you call this an outbreak? And I guess this is not the most interactive setting, so if anybody wants to respond through the chat box, we'll be happy to share that. And maybe while they're doing that, I can just ask you, Jennifer, do you consider this an outbreak?
So thanks, Heather. Yes, so I actually would consider this an outbreak. And I would for a couple of reasons. First of all, that's a pretty high attack rate, and a pretty high number of people who attended the supper and who then became ill. So, of the 75 persons interviewed, 46 reported GI illness. And so I would definitely consider that an outbreak, taking into consideration the number of persons affected, but also the fact that they were present at that supper.
Okay, so we're looking at the person, the place, and the time.
Exactly, that's right. Person, place, and time.
Good to me.
So, so I think the second question was to review the steps of an outbreak investigation. And again, I know that's a little bit challenging here, but I do have that on the slide for you. And so again, I'll just read through those quickly, but the 10 steps of an outbreak investigation. First of all, identify your investigation team and your resources. Just make sure who you would call and where you would find additional information should you need either of those. The second one is to establish the existence of an outbreak, and we did talk a bit about how to identify if you do have an outbreak. The third step was to verify the diagnosis, and we did talk as well about how to verify that diagnosis, making sure that you look at the medical record, the laboratory information, so any clinical information that you might need. And then fourth, looking at that case definition, so making sure you have a case definition to compare the people that you think might be associated with the outbreak, so to include those, and then also, conversely, to exclude them from that. The fifth one is to find cases systematically and developing a line list. And again, that stems from having that case definition that you can compare people to. And then sixth is to perform descriptive epidemiology and to develop your hypotheses or your best educated guess. And those descriptive epi components that we talked about include the line list and also the epi curve, or the epidemic curve. The 7th step is evaluating the hypotheses and then performing additional studies if needed. And this is the component that we talked about, where you can implement a cohort or a case control study in certain circumstances. And again, you do not always need to do that. The 8th step was implementing control measures. Again, keeping in mind that you will implement immediate control measures in almost every investigation, and then you will change those control measures throughout the investigation. The 9th step is communicating those findings, both oral and written, to a variety of individuals and partners. And then the 10th step, maintaining surveillance, just making sure that your outbreak is indeed over. So if we've established that this is more cases than we would expect, and we're calling it an outbreak, then I guess we're kind of moving into that step 3. So we're looking at the diagnosis. Right. Okay. Yep. We would right here anyway.
So we're going to look at the clinical description of these cases. So the onset of illness in all cases was acute. It was characterized primarily by nausea, vomiting, diarrhea, and abdominal pain. None of the ill persons reported having an elevated temperature, and all recovered within 24 to 30 hours. Approximately 20% of ill persons visited a physician, but no fecal specimens were obtained for further examination. So the next question is to list the broad categories of disease that must be considered in the differential diagnosis of an outbreak for GI illness. And so if you guys could use that chat box and just kind of shout out or type out, I guess, as the case may be, some of those broad categories that you would be thinking about if you heard of a situation like this. So again, those symptoms: nausea, vomiting, diarrhea, and abdominal pain, no fever, and everybody recovered pretty quickly within about a day. So I see somebody saying salmonella. Okay, so we're looking at something infectious. Any other guesses?
Yeah, and salmonella would fall into that bacterial category.
Norovirus. Yeah, maybe that short duration could tell you that it could be a neuro.
Mm-hmm. So far it looks like we've got some bacterial and viral. So both of which are, could be correct. So those are infectious complications or infectious causes of gastrointestinal illness.
It sounds like maybe everybody's going to that picnic as the common factor. I think at this point, we also don't know. We haven't looked at those risk factors and line lists, so it's possible this could be something toxic or maybe environmental. Food poisoning.
Yeah, right. Exactly. So some of the broad categories. So we've heard viral, bacterial, which would fit into the infectious, and then as Heather, you mentioned some of the toxic and environmental. So it could be a toxin as well.
Maybe a heavy metal.
Right, heavy metal. Because those tend to be very, they act very quickly. So you consume the meal or whatever it is, and you become ill within a certain number of hours, and it's very short. It's a short incubation period.
But it seems like, as most of you were thinking, the investigators are suspecting that this could be a vehicle-borne outbreak with food as the vehicle. So what is a vehicle? And what are some other mode of transmission? So when I say food is the vehicle, what does that mean? If anybody wants to answer that in the chat box, we can kind of talk through that. Okay. Yep. As a mode of transmission, absolutely. And specifically when we're talking about a vehicle, we're looking at a non-living mode of transmission. So food, water, any inanimate object, so bedding, a surgical scalpel, anything that allows that infectious agent to be transferred to a host.
Yeah, exactly. And sometimes we hear the term vector, and so what do we think of when we use that term vector? So a vehicle is a non-living substance, and a vector is actually a living intermediary. And so we think about the vector-borne diseases. An animal, that's right. Yeah, so vector. So it's a living intermediary. So definitely vehicles and vectors can be important routes of transmission, modes of transmission. Other modes of transmission, direct contact, so direct exposure to a person or an animal or its products, so mucous membranes, skin-to-skin contact, fecal-oral contact. Any other modes of transmission that you guys can think of?
if you think of your types of precautions, that's often a clue.
So contact, fomite,
Mm-hmm.
airborne. That's what
Absolutely.
I was looking for.
Yeah.
Yeah.
So that would be something like Legionella. We can also look at droplet. So when we look at somebody sneezing or coughing.
Yeah, so droplet and airborne, so that's exactly right. So those are other forms of disease transmission as well. All right, so moving on. Question 5, if you were to administer a questionnaire to the church supper participants, what information would you collect? And group the information into categories. So if you think of your line list, what type of information would you want to collect and put into that line list? Time onset, perfect. So some of that clinical information. What did you eat? Exactly.
Risk factors, definitely. We also need to be able to tell these folks apart, right? So we're going to ask for some identifying or demographic information.
Yeah, and if you need to reach back out to them, it'd be nice to have some sort of contact information.
Anything else you would want to include on there right now? I think what did you eat kind of gets to it, but in general, we want to be asking about any potential exposure. So right now, we suspect that it could be food, but we definitely don't want to rule something else out too quickly.
Exactly. So we're looking for all types of risk factors here.
Okay.
All right. So next one, Dr. Rubin put his data into a line listing, which is what we just talked about. So what is a line listing, and what is the value of a line listing?
So the line lists here, we're talking about those spreadsheets where each row represents a single case, and it's how we're going to incorporate all of that information together. So we're going to represent different variables like phone number and age, risk factors, onset information, any clinical symptoms. Absolutely, yes. I see a comment here. This is to help you organize your data. Definitely.
And we as epidemiologists love our line list.
It's also a quick summary. So when you're responding to something, you don't necessarily have the time to really sit and do a deep dive into what's going on anytime you want to answer a question. And so a line list can give you a quick count. How many people had nausea? How many people ate this specific food?
That's right. So it's a great summary.
Yeah. So it says it helps determine the source of transmission and can sometimes provide cues about the infectious agent.
Right.
Definitely.
Yeah, so you really can tell a lot from a line list. So you can tell, you know, kind of quick and dirty, the number of people affected, perhaps even the time of onset, if there's kind of something that keeps popping back up. So time of illness onset, and also risk factors, and maybe any other clinical signs and symptoms.
Yeah. So I really just can't overstate enough how important a line list is to an investigation.
All right, so moving on, part 2, so description of the supper. So the supper was held in the basement of the village church. Foods were contributed by numerous members of the congregation. The supper began at 6 p.m. and continued until 11. That's a long time. Food was spread out on a table and consumed over a period of several hours. Data regarding onset of illness and foods eaten or water drunk by each of the 75 persons interviewed are provided in the attached line listing. The approximate time of eating supper was collected for only about half of the persons who had gastrointestinal illness. So question 7, so what is the value of an epi curve?
So showing here is our epi curve that we took from those data we collected. So this is the cases of GI illness by time of onset of symptoms in hours, and this is over April 18th and 19th in 1940.
So it's too bad that we actually only collected about half of the persons who ate with the time that they ate. So we only have about half of those people who were affected. So that's a little too bad, but we can still tell quite a bit right here.
Right, so this is like a visual representation of those data that we collected. And as we talked about when Jennifer reviewed epi curves earlier, this is a really great way to try to get a sense of the route of transmission and the mode of transmission. So what we see here in the middle is this pretty defined peak. So to me, that starts to suggest that maybe there was a common exposure. It also helps us look at the magnitude, so we can quickly eyeball the number of cases we have here. And it also shows where we are in the epidemic. So is it, or the outbreak, so is it still occurring? Or have we seen tapering off of cases? Do we think the outbreak has ended?
Yeah, so can we tell are control measures working if they implemented control measures? Yep.
And I think also looking at those two outliers, so the person that looks like they got ill very, very early and the person that got ill much later than everyone else, it can start to draw our attention to those outlier cases to ask, are there specific questions we should ask about what's different about those individuals?
Yeah, exactly. I think looking at the outliers is always an important component of epi curves and outbreak investigations.
And I see here, so the epi curve helps determine the average onset of illnesses, which is exactly right.
Yeah. So I think there's actually a line list that you all have. I think it's on page 6 and 7. And so how could the data in that line listing be better presented? If you just want to type into that chat box how it could be better presented.
Hopefully you all have the handout.
Organized by onset time, absolutely. Yep. Yeah, so onset time, and anything else that you all noticed about that? Were kind of the people who had become ill, were they separated out?
So that's another thing we'll often do here in the course of our outbreak investigations, is being able to quickly look at who's sick and who's not, as well as the onset time.
Right. All right. So those were two ways that line list could be improved upon. So separating ill from non-ill, and then obviously sorting by time of onset, which you all got. So question 9: are there any cases for which the times of onset are inconsistent with the general experience, and how might they be explained? And I know Heather actually alluded to this. So we looked at the epi curve, and there are 2 cases that appear to be outliers.
And so that first case there, that's actually subject 52 if you're looking at the line list, but that was an 8-year-old boy. And when we looked at his responses, what we found was he actually ate early. So he ate at 11 a.m., even though the supper didn't begin until 6 p.m. So the typical incubation period when we looked at these cases was about 4 hours. So some of the questions we might want to ask about this individual was, maybe it's an 8-year-old boy who has GI illness for another reason. Maybe it's not associated with the outbreak, or maybe he was there when the food was being prepared. Is he the cook's son? If that's the case, then we might want to think about what foods would have been ready at 11 a.m. when he was eating.
Yep. Yeah, and the second inconsistent case is subject number 16. It's actually a 32-year-old woman. And so, did she have a long incubation period? I don't know that we actually have that information. We don't know when she ate. Was food taken home and eaten later? Did she have an unrelated illness? I think there are a lot of other questions that we could ask.
Or maybe it was a data entry error. So maybe somebody put the time in wrong. That's also a question to double check on.
Okay, so we are actually going to move on to part 3, and I apologize because we actually had a supplemental line listing for you that we would have handed out, but we actually did have that sorted by illness status, well or ill. I have it in an Excel file, but not yet. And also by time of onset. So that would have actually made these next questions a little bit easier for you to calculate. So question number 10, determine the range, incubation period, and median of the incubation period. So I've actually kind of stratified it here for you on the slide.
And so when we're talking about range, just to make sure we all have the same terminology, what we're looking at is we want to look at the minimum and the maximum number of hours for incubation period. So yeah, so that's from 3 to 7, so the range was 4 hours.
Perfect.
And then if we're looking at the median, so there's lots of measures of central tendency we can look at, but when we look at the median, that is going to be least influenced by those outliers. And so we want to look at so the way this is arranged, you can actually just count to the middle case. So if you look down the line, what is the median case? So there are 22 total cases. So we're going to look in between that 11th and 12th case, and so that's a median incubation period. Highlight this.
We did. There you go.
Oops. So. And so we're looking right here, and they had 4 hours. Yeah, but I see lots of people responding, but they were able to do that as well. So 4 hours.
All right. Hopefully that makes sense to people. So it sounds like you were on the right track there with a range of 3 to 7, and let's see, and the median of the incubation period. Okay. So question 11. How does the information on incubation period combined with the data on clinical symptoms help in the differential diagnosis of the illness? I know you talked a little bit before when you were kind of shouting out some of the suspected agents. So I heard salmonella and norovirus, and what kind of would factor into that for you?
So when we think about a really short incubation period, that usually makes me think of some kind of toxin, whereas a longer incubation period might mean that it's a disease process that has to occur. Maybe microbial growth has to happen before they see symptoms. Right. So this observation period, we're looking at 3 to 7 hours with a median of 4. So that's probably too long for toxins like a botulism.
And too short for a lot of viruses.
Yeah.
Viruses usually, kind of that between 24 and 72 hours.
So what it's consistent with, and if this is not, if you're not constantly looking at foodborne outbreaks, you might have to go to your resources to look at CDC or the Control of Communicable Disease Manual. And what we can say from looking at those is this is really consistent with a period for fish toxins, toxic mushrooms, Staph aureus with enterotoxin. But when we look at the line list, we can say it's probably not a fish toxin because we don't have the same kind of symptoms that we normally see. Looking at the types of food that they ate, you can try to start to eliminate some of those other groups as well.
Yeah, exactly. Yeah, so I tell you what, having some of these data available to you, especially the incubation period and the clinical profile, it can really kind of direct the diagnosis of what you're looking at. So question 12. So using the data and the attached or supplemental line listing, complete the table below. So that, I think that table is actually completed for you, I think. And which food is the most likely vehicle of infection? Can somebody just type in whether you actually have that completed for you?
With the attack rates, can you see that on your end?
Vanilla ice cream. Okay, perfect. Okay, good. All right. So the vanilla ice cream. Yeah, and so that was actually a really good guess. And so can you tell me why you actually think it was ice cream?
The highest rate of,
it's circled. Oh, okay. That was good. All right. Yeah, it's the highest rate of sick versus the lowest non-sick. And that's actually, right. That's one of the things that we would look at. So we call that an attack rate ratio. So one of the things that we look at in epidemiology is, how many people who got sick kind of consumed that food item. And then we look at it, similarly, kind of vice versa for those people who did not become sick. And so then we create a rate ratio with that information.
Yep, and so you can see, looking at the vanilla ice cream, 80% of people who ate the food were ill, giving out an attack rate of 5.7.
Right.
And that's much higher than all of those other foods that were eaten.
Awesome. Excellent.
So question 13, this is going back to those outliers that we talked about earlier. So we want to look at what might possibly explain why these two cases had attack rate, still were sick, despite their atypical time of symptom onset. So can anybody think of the ways that we could do that?
Interviewing.
Absolutely.
Yeah, so some of the things that we would want to know from those people interviewed, you know, how was the food prepared? Would we interview actually the people that prepared the food, or would we just interview the people that consumed the food? Ask when they ate the ice cream. So what time, right?
Yeah. It's possible that maybe we could be seeing some secondary spread, so we would want to follow up on that as well. So it looks like most of these cases came from a single source, but sometimes we see infections outbreaks start from a point source and then have some person-to-person transmission later on.
Ask if any of that product was taken home. Did they consume it afterwards?
Eaten as leftovers, certainly. So based on all the information we have here, what control measures would you suggest? Particularly around that food that looks like it's the culprit. Is there anything we could do to prevent people from getting sick? Get rid of the ice cream, yeah.
Absolutely.
And we might not want to throw it away. We might want to save it to see if there needs to be a sample, but definitely remove the ice cream.
Yeah, just make sure that nobody else eats it. I kind of determine.
Sorry, I just also see here somebody saying determine who made the ice cream and if a recall is needed. So yeah, was this homemade ice cream or was it something they bought at the store? And could this outbreak be a sign that we might be having a lot more responses like these?
Yeah, exactly, and that's where I was going to go. So you beat me to it. So determine whether it was homemade or whether it was purchased at a store. And again, as was just mentioned, just make sure that no one else eats it. So prevent consumption.
Another control measure that I would suggest at this point is education. So even though the ice cream is removed, let's talk to those food handlers and make sure that they know proper techniques to prevent similar occurrences in the future.
Yeah, and I saw that somebody else just typed in here too, and it's something that we have also talked about. So yes, determine if any was removed from the supper. So make sure that that no one else consumed it after the supper. Make sure that if they do have it at home, that they should go ahead and throw that out. So the next question, so why was it important to work up this outbreak? You know, I think at this time frame, we don't know if this had ever happened before.
So for a lot of the same reasons, we're working up outbreaks today. So we needed to rule out, just as you guys are suggesting here in the comment sections, that there's not contamination of a commercial product to prevent additional cases. We want to make sure we're preventing future outbreaks by identifying infected food handlers or education gaps so that we can have proper techniques in the future. So we're investigating this outbreak to stop this outbreak, but also to prevent future outbreaks.
Yeah, and one of the other things that we talked about was, the public concern and the public education. So, who knows if, public concern was elevated during that time, but I imagine that it probably was. It was a pretty small community from my understanding.
So the next question, refer to the steps of the outbreak that we outlined in question 2, and just think through how does this investigation fit into that outline? Were there any steps that we missed? Let me see, maybe try to go back to those steps for you. Maybe. Did we miss any of these steps when we went through this outbreak?
Yeah, one, I'm not sure I would know how to classify people, right?
Yeah.
I'm not sure if I would
Who is going in the box? So maybe they did it on site, but when we, yeah, exactly, a case definition.
Right. Yeah, so that was, I think, a pretty glaring omission here for this investigation. So we don't know how to classify people and if we would include them in the outbreak case definition or not, because we didn't have a case definition. Yep. Anything else? I know we had kind of a line listing, and we did have an epi curve. But could that have been improved upon?
I know one of the things that we do here with our line list often is that descriptive epi. So coming up with kind of a table 1 where we start to talk about what was the average age and were there differences by gender, just making sure we're using those data to really inform what we know about the outbreak.
Yeah, exactly. I think that it definitely could have improved upon the line list in particular. It was pretty messy. So.
All right.
All right, so I think we're on to part 4, the conclusion.
Yeah, and so somebody's saying,
right,
separating out those who are ill compared to those who are not ill. Absolutely.
Exactly. So that goes back to the line list. It really could have used some help. All right, so part 4, conclusion. The following is quoted verbatim from the report prepared by Dr. Rubin. The ice cream was prepared by the Petrie sisters. All handles of the ice cream were examined. No external lesions or upper respiratory infections were noted. Bacteriologic examinations were made by the Division of Laboratories and Research, Albany, on both ice creams. The report is as follows. Large numbers of Staphylococcus aureus and albus were found in the specimen of vanilla ice cream. Only a few staphylococci were demonstrated in the chocolate ice cream. So discussion as to the source. The source of bacterial contamination of the vanilla ice cream is not clear. Whatever the method of the introduction of the staphylococci, it appears reasonable to assume it must have occurred between the evening of April 17th and the morning of April 18th. No reason for contamination peculiar to the vanilla ice cream is known. In dispensing the ice creams, the same scooper was used. It is therefore not unlikely to assume that some contamination to the chocolate ice cream occurred in this way. This would appear to be the most plausible explanation for the illness in the 3 individuals who did not eat the vanilla ice cream. So control measures. On May 19th, all remaining ice cream was condemned. All other food at the church supper had been consumed. Conclusions. An attack of gastroenteritis occurred following a church supper at Lycoming. The cause of the outbreak was contaminated vanilla ice cream. The method of contamination of ice cream is not clearly understood. It's important to note that patient 52 was a child who, while watching the freezing procedure, was given a dish of vanilla ice cream at 11 on April 18th. And some additional information that's provided to us. Certain laboratory techniques not available at the time of this investigation might prove very useful in the analysis of a similar epidemic today. These are phage typing, which can be done at CDC, and identification of staphylococcal enterotoxin in food by ELISA, which is available through the FDA. If the contaminated food had been heated sufficiently to destroy staph organisms but not toxins, analysis for toxins would still permit detection of the cause of this outbreak. A Gram stain might also detect the presence of non-viable staph in contaminated food. So that's the discussion of, or the conclusion of the outbreak. And then for your consideration, question is posed here. Would cultures of individuals be appropriate, such as cultures of others who might have been in contact with the ice cream in preparation? So that's just kind of food for thought, and something that, you know, sometimes we frequently receive that question as well.
So I see a question here about the control measures. They're asking, did they mean April 19th on the conclusion of the control measures?
And they very well might have.
So the control measures say on May 19th, yet all remaining ice cream was condemned. I think likely they April 19th.
Yeah. Likely they did.
Hopefully it wasn't a month later.
Sometimes it actually does take a while to conclude the study, though, so it could have very well been May 19th.
So questions about this exercise or anything we've talked about today, or something we haven't talked about today that's related to outbreak response? They may be mismaintaining surveillance. Yeah, so they definitely don't talk about ongoing surveillance in this community, but hopefully they continue to monitor the folks that went to the picnic until at least 2 incubation periods for that organism passed to make sure we weren't seeing secondary cases.
Right. And usually with a point source outbreak, such as, you know, an event like this, that maintaining surveillance for those 2 incubation periods would be a little, I guess, less necessary than some other outbreaks that might occur, such as an infectious disease that's really communicable from person to person.
So if you're really sure you've removed the source, then likely you would see that steep drop off on the IV curve.
Exactly.
So those are all the questions we're seeing. Amy, are you getting any questions on your end?
I am not seeing any questions other than what you're seeing. So certainly do appreciate you all and the presentation. Very interesting outbreak investigation. And we will, I'll be sending out an email shortly to everybody with sort of an update on our process for tomorrow's presentations, but I do want to thank Jennifer and Heather for your presentation this afternoon. Thank you so much. Like I said, we will be sending out an email to further update you about presentations tomorrow. It's looking like at least our morning presentations will be in a webinar format, not the entire day. So look for that email from me, and please email me if you have any questions. Thanks, everybody.
And I just wanted to thank everyone as well for their time and attention today. And it would have been lovely to meet everyone in person, but hopefully our paths will cross in the future.
Yeah, thank you all, and thank you for the patience with the unconventional format.
Thanks a lot, you guys.
Okay, bye.
Bye-bye.
Bye-bye.
Did it look like most of them were on there?
Yeah, 40, a few have popped off, but 47, and there were a few more. But
Yeah.
discussion. Yeah.